Hello dear friends, how are you doing today? I hope you are doing well. Today we are going to talk about herpes simplex. Definition: herpes simplex is an acute self-limiting intraepidermal vesicular eruption caused by infection with HSV. HSV is a DNA virus that replicates within the nucleus. Based on culture and immunologic characteristics, it is divided into two types, HSV1 and HSV2. Usually HSV1 causes oral infection and HSV2 causes genital infection. Primary infections with these viruses are characteristically followed by recurrent attacks. Herpes simplex grouped vesicles on an erythematous base. Incidence: infection with HSV is common worldwide. It is estimated that in the United States more than 50% of adults are seropositive for HSV1 and more than 20% for HSV2. History: primary infection with HSV1 usually occurs in children, in whom it is subclinical in 90% of cases. The remaining 10% of infected children have acute gingival. In contrast, HSV2 primary infection usually occurs after sexual contact in postpubertal individuals, and it produces acute vulvovaginitis or progenitalis. Primary infections are frequently accompanied by systemic symptoms that include fever, malaise, myalgia, headache, and regional adenopathy. Localized pain and burning may be so severe that drinking and eating or urinating may be compromised. Infection of the lips, also called herpes labialis, is usually caused by HSV1, whereas the genitals and buttocks are more often infected with HSV2. The risk of a woman developing genital herpes on exposure to an infected man is estimated to be 80 to 90%. The risk of recurrence after primary genital infections is less with HSV1, which is 14%, than with HSV2, which is 60%. Recurrent attacks are preceded by localized itching or burning and are characterized by their occurrence in the same location. This prodrome usually begins within 24 hours before the appearance of the eruption and occurs in approximately 2/3 of patients. HSV infections are not limited to the lips and genital area. Either type can infect any area of the skin. Therefore, a history of a vesicular eruption recurring in the same location should lead to a suspicion of HSV infection. Physical examination: indurated erythema followed by a grouped vesicles on a red inflamed base is typical of herpes infections. The vesicles quickly become pustules with rupture, whip, and cross. Affected skin sometimes becomes necrotic, resulting in punched out ulceration. Note: grouped vesicles on a red base are characteristic of HSV infection. Primary infections or gingival or vulvovaginitis are characterized by extensive vesiculation of the mucous membranes. This results in erosions, necrosis, and a marked purulent discharge. Herpes infection can develop in any area where inoculation has occurred. Recurrent herpes infections are characterized by localized grouped vesicles in the same location. Herpetic white low is an infection of the finger. This is an occupational hazard for medical and dental personnel that can be prevented by wearing gloves. Traumatic herpes simplex has been reported in epidemics among wrestlers, is called herpes gladiatorum. Eczema herpeticum is a generalized cutaneous infection with HSV in individuals with predisposing skin disease such as atopic dermatitis. It is accompanied by severe toxic symptoms and may be fatal. Differential diagnosis: impetigo contact dermatitis and less often superficial fungal infections may be confused with herpes simplex and can be ruled out by the histogram staining and culture of the blister fluid. Patch testing with suspected allergens and potassium hydroxide preparation test of the blister roof. Laboratory and biopsy: the occurrence of grouped vesicles on an erythematous base is characteristic of HSV infection. Polymerase chain reaction assay or PCR is the preferred method to diagnose herpes infections. Being being rapid, specific, and sensitive. A zinc smear, which reveals multinucleated giant cells, is a simple yet reliable method of confirming a herpetic infection. Smears from the base of the lesion stained with Giemsa, white, or Toledo blue demonstrate multinucleated giant cells, which are diagnostic of HSV infection. Zinc smear multinucleated giant cell. The positivity of the zinc preparation varies with the lesions sampled. Vesicles 67%, pustule 55%, and crust or ulcer 16.7%. A high correlation exists between zinc preparation and viral culture. However, when performed properly, the culture has greater positivity. Vesicle 100%, pustule 73%, and crust or ulcer 33%. Direct immunofluorescent staining of vesicle smears compares favorably with viral cultures. Although usually not necessary, the biopsy reveals an intraepidermal blister with multinucleated epidermal giant cells and an acute inflammatory process. Patients with genital herpes should be screened for other sexually transmitted disease. Note, zinc smear revealing multinucleated giant cells confirms a herpetic infection. Note, PCR or vesicle-based fluid is an effective and efficient diagnostic test for herpes viral infections. Herpes simplex, epidermal bulla multinucleated giant cells, which is showed with arrows, and dermis, we can see perivascular inflammation. Therapy. Acyclovir, valaciclovir, famciclovir, panciclovir, and doxazonol are the drugs of choice for HSV infections. Their low toxicity and specificity for HSV have resulted in widespread acceptance. The unique mechanism of action accounts for the selectivity against HSV. Acyclovir is a synthetic acyclic purine nucleoside analog. Phosphorylation of acyclovir depends on HSV-specific thymidine kinase. This enzyme converts acyclovir to acyclovir monophosphate, which is phasically converted into acyclovir triphosphate by cellular enzyme. Acyclovir triphosphate inhibits viral DNA polymerase and replication of viral DNA. It is effective against replicating viruses but does not eliminate latent viruses. Valaciclovir is a prodrug that is better absorbed than its metabolite acyclovir. Famciclovir, also a prodrug, is metabolized to penciclovir and synthetic acyclic guanosine derivative. Panciclovir shares a similar activation pathway with acyclovir that depend on viral thymidine kinase to form panciclovir triphosphate, which halts DNA synthesis. In active infections, these antiviral drugs decrease the duration of viral shedding, accelerate healing of the lesions, and may reduce local and systemic symptoms. For genital herpes infection, condom use can prevent the transmission of HSV2 by 50% and should be encouraged for individuals with active and asymptomatic shedding for the virus. Intravenous acyclovir is indicated in the treatment of severe primary HSV, including eczema herpeticum, and in initial and recurrent infections in severely immunocompromised patients. The most important adverse reactions are the deposition of drug crystals in the renal tubules of patients with inadequate hydration or impaired renal function. Resistant strains of HSV have emerged in immunocompromised patients and have posed a significant clinical problem. Foscarnet is an alternative drug if acyclovir fails because of acyclovir-resistant thymidine kinase deficient HSV. Note, condom use decreases the transmission of HSV2. The conclusion of therapy for herpes simplex: initial therapy for first episode of primary acyclovir 400 mg TID for 7 days, 5 to 10 mg per kg IV every 8 hours for 5 to 7 days. Valaciclovir 100 mg BID for 7 days, or famciclovir 250 mg TID for 7 days. In recurrent cases, acyclovir 800 mg TID for 2 days, 5% ointment every 2 hours for 7 days, valacyclovir 2000 mg BID for 1 day, famciclovir 1 gram BID for 1 day, acyclovir 5% ointment 6 times daily for 7 days, penciclovir 1% cream every 2 hours while awake for 4 days, or doxazonol 10% cream 5 times daily until healed. In chronic suppressive cases, acyclovir 400 mg BID, valacyclovir 1000 mg daily, or famciclovir 250 mg BID, and alternative therapy include foscarnet 400 mg per kg every 8 to 12 hours for 1 to 2 weeks. Course and complications. The incubation period after contact with HSV is approximately 1 week. The clinical course of the primary herpes infection lasts approximately 3 weeks. A prodrome of 1 to 2 days is followed by a vesiculopustular eruption that continues for about 10 days. This phase is followed by a corrusting ulceration and healing after a further 10 days. For most patients, HSV is an asymptomatic chronic infection of the sensory ganglia. Overt eruptions recur in a minority of infected persons after varying periods of latency, during which the virus remains dormant within the dorsal nerve root ganglion corresponding to the site of infection. Recurrences have shorter courses of 1 to 2 weeks. Several factors including fever, ultraviolet light, physical trauma, menstruation, and emotional stress are attributed to initiating recurrence. Asymptomatic subclinical shedding of the HSV is common and is instrumental in transmitting HSV to others. The immunocompromised host is most at risk of developing complications from HSV infections. These complications include chronic ulcerative herpes simplex, which lasts for weeks to months, generalized acute mucocutaneous herpes simplex, and systemic infection involving the liver, lung, adrenal glands, and central nervous systems. A chronic cutaneous herpes simplex, red crusted plaque. HSV infection of the neonate or neonatal herpes is devastating but fortunately uncommon disease. The fatality rate without treatment is more than 50%, and at least 50% of the survivors have significant neurologic sequelae. A significant reduction in mortality and morbidity occurs with acyclovir treatment. For women who have evidence of an active HSV infection at delivery, a cesarean section is recommended. Complicating neonatal HSV infection, however, are the findings that cultures to screen women immediately before delivery do not predict infection for the fetus. More than 70% of mothers or babies with neonatal HSV have no history of genital HSV infection, and symptomatic disease may not occur for as long as 1 month after delivery. 2/3 of affected infants have mucocutaneous manifestations of HSV infection. Note: untreated neonatal herpes is frequently fatal and has severe morbidity. Neonatal herpes simplex grouped vesicles on a red base of the lip and arm. A relatively uncommon complication of HSV infection is erythema multiforme. Immune complexes composed of antibodies and HSV antigens have been found in the serum of patients with erythema multiforme after HSV infection. These immune complexes may be the pathogenesis of the vascular change seen in erythema multiforme. In addition, HSV DNA has been found in the lesions of erythema multiforme associated with HSV infection. Note: in most cases of neonatal herpes, the mother has no history of genital disease, and it may take up to 1 month after delivery for symptoms to develop. Pathogenesis. HSV is a highly contagious variant spread by direct contact with infected individuals who are often asymptomatically shedding the virus. Studies of shedding and survival of HSV from patients with herpes labialis have detected herpes virus in their saliva 78% and on their hands, which is 67%, with virus viability on skin, clothes, and plastic for 2 to 4 hours. The virus penetrates the epidermal cell, in which a complex series of steps occurs. The virus undergoes a replicate cycle and induces protein and DNA synthesis with the assembling of intact virions and eventual lysis of the host cell membrane. New copies of viral DNA are packaged into cuspids, which are then covered with an amorphous tegmentum. The viral envelope, which contains virus-specific glycoproteins, is formed by budding through the host nuclear membrane. This process requires an intact host cellular metabolism for substrate synthesis and replication. The destructive effect on epidermal cells results clinically in intraepidermal vesicles. Latent HSV, undetectable by tissue culture, electron microscopy, and immunofluorescence, presumably rise in the dorsal nerve root sensory or autonomic ganglia in a non-replicative state. Outbreaks occur with reactivation of the replicative cycle, production of new viruses, and spreading back down the nerve. Latency within the ganglion cells is possible apparently because the HSV genomes within these cells are relatively well protected from immunologic attacks. Clinical case: a 23-year-old woman presents with painful skin lesions around her lips that appeared 2 days ago. She reports a burning and a tingling sensation in the area before the lesions develop. She recently had a mild fever and fatigue. On examination, there are multiple grooved vesicles on an erythematous base located on the upper lip. Some vesicles have ruptured, forming shallow erosions and crusts. The lesions are tender and there is mild swelling of the surrounding skin. What is the most likely diagnosis? A. Impetigo. B. Contact dermatitis. C. Superficial fungal infection. And D. Herpes simplex. Okay, it's clear that the diagnosis here is herpes simplex. Okay, this was a short explanation about herpes simplex. Thank you for your attention.